So Spokane County is one of the fourth largest populated counties in Washington State. We have about 470,000 individuals. If you look at the area that I oversee in my division, the communicable diseases, they're low, but we also have our challenges in communicable diseases with providers reporting to us in a timely manner and us following up on those reports in a timely manner.
So we investigate reportable diseases, so chlamydia, gonorrhea, and syphilis. So we were probably dealing with about 1,700 cases of chlamydia a year, plus you top on gonorrhea and syphilis to that. So we had quite the incidence and prevalence of sexually transmitted diseases.
The state of Washington, like many states, has actual health regulatory codes which dictate that we report certain diseases, and in the state of Washington that would be gonorrhea, chlamydia, syphilis, and our statutes require reportability within 3 days.
We were realizing that we were getting case reports 3 or 4 weeks after the diagnosis, and it became very apparent our efforts of doing case investigation were horribly thwarted because by the time we would reach a client, it would have already been a month. They weren't aware of their diagnosis or they hadn't been treated yet.
STDs really stood out as way outside of the requirement. And so we knew that we needed to do some type of improvement project with the providers to get better reporting.
We looked at January to June 2010 and we calculated a baseline. We said, okay, so it looks like the county is reporting about 7-day average. So I looked at all the clinics that were reporting more than 7 days. There's 27 clinics total. From August until December 2010, I either went and did a face-to-face with these clinics, or I also did telephone conversations, like conference calls.
So just sitting down and understanding the culture of information flow in each practice was half the battle, and that led to a discussion for areas of improvement and enhanced communication.
I shared the reporting statistics for them for their baseline from January to June. So covered the current case report, and we basically had unstructured brainstorming sessions about, what areas of their clinic could we identify at that time to which we could actually put in an intervention, see if we could evaluate that and see how it was working.
So this, as obvious as that sound, is rather unique. Why not go to the people that are at the point of service and find out what are some of the barriers to meeting these regulations and just the standard of care?
I was really surprised about the turnover. I didn't realize it was that great, that actually posed probably one of the greatest risks to effective reporting, is just because the loss of knowledge happens so quickly. Most of them were using an outdated case report form. They weren't even aware that there was a new form. Additionally, they didn't know that you had to report within 3 days.
A fresh pair of eyes to look at something that a clinic like us might have done for 10, 15 years and saying, why do you do that? And, well, we don't remember. And then finally, something good happens when the reviewers review 27 practices as they bring information to us which helps us get better and more compliant.
By far the key players were the medical assistants. They are your frontline staff. If you kind of penetrate the MAs and are able to get in with them and do any one-on-one or any education with the entire staff, by far you will effectuate change.
If I were to pick the single most effective thing that we learned, is that my medical assistant, who was in charge of follow-up and processing positive results for these reportable diseases, now knew a person in county health, so there could be a dialogue about common problems.
And after the activities or strategies that the staff used, we saw a substantial drop in the days that it was taking reports to get completed.
In the end, after we did our post-intervention results, so we were hoping to decrease the 14 days to at least 10 days by June 2011. And we did in fact reach a 9.5-day county average. So really it was a huge impact. Yes, while that is still outside the 3-day range, that was still a 64% increase among the clinics who are actually reporting within the county average time frame.
The QI project taught us how to think again and how to partner and communicate. Quality improvement actually makes clinicians start thinking more broad and how to connect resources, because all of us come to work and want to provide the best care we can for our patients.
I mean, this is really what we do in following up on communicable diseases. And there really is nobody else out there that's going to take on these quality improvement projects and work with the providers.
The lessons learned are transportable to any county, and so I'm excited about that. And I would love to see the same kind of QI project on a different area, let's say immunizations from a different city, so that I can learn their best practices. Let's share this information and all boats rise. So everybody can do this. Every county health district can improve care. So let's not reinvent the wheel, work together and share this information.